Okay, students, so I am recording finally. I know I planned to do this before, but I'm doing it now. The remainder part of intrapartum complications, and we were on this slide, and I'm going to try to do this in the 15 minutes that it's going to allow me. So this is the passenger piece that we're talking about, and interestingly enough, amniotic fluid is part of the passenger because it comes from the fetal tissue. So we're going to talk about some of these problems. Anaphylactoid syndrome used to be called pulmonary embolism, but it's now called anaphylactoid syndrome. But it's still the same thing. It's where fluid gets into the maternal circulation and then goes into the maternal lungs and sits there, causing a pulmonary embolism. It's either fluid, the amniotic fluid, it's vernix, it's lanugo, it's hopefully not meconium stained fluid, but it can really cause mom's problems. Very frequently we lose a mom whenever they have a PE. They often go into DIC and then we have to transfuse with blood. So that's not a good thing. Polyhydramnios is where we have greater than 2,000 mLs of fluid. Very, very excessive. Picture two IV bags full of fluid, along with the baby in the uterus. So oligohydramnios is less than 500. That's not enough fluid to keep that uterus suspended up off the baby. And we would need to take action if that's how much on ultrasound it was determined that the mom had in her uterus. So we would then do an amnio infusion, and it is warmed fluid of saline or lactated ringer, something that's isotonic, into the uterus through that IUPC. We are going to mark the top of the uterus to see where it is on her abdomen, and then we don't want it rising too far because then fluid is staying in and not coming out. There should be fluid all the time coming out so that we don't, in a sense, burst her uterus like we would a water balloon. We are going to use amnio infusion to treat decreased amniotic fluid, episodic decelerations, which are those variables, which is cord compression, and to dilute medium to heavy meconium staining, where the infant had a bowel movement while still in utero, and then premature rupture of membranes longer than 24 hours. So, of the amniotic fluid considerations, infection is a hugely serious side effect. Chorioamnionitis is what this is called. It's infection of the chorion and the amnion. Postpartum, it's called endometritis. Babies can succumb to chorioamnionitis. Moms can usually fight this off because they have a more mature immune system. So we have different kinds of ways to describe ruptured membranes. Premature rupture of membranes is 1 hour before onset of labor. I think I said before it was 24 hours, but it's 1 hour before onset of labor. P-PROM is preterm premature rupture of membranes, so longer for an hour and before the term gestational age of 37 or 38 weeks. And then prolonged rupture of membranes is greater than 24 hours, and we really don't want a situation where membranes have been ruptured longer because we are going to end up with chorioamnionitis. So amniotic fluid considerations, very subjective description, and this is that gush, and we are going to use the coat, color, odor, amount of time. We are going to watch her temperature like a hawk. So if it goes greater than 100.4, which is 37 Fahrenheit, if we are going to see maternal fetal tachycardia, which is also another objective way to see that she's getting a fever, abdominal palpitation or contractions are causing uterine tenderness, it's hurting her, then that's usually something is setting in. We can see a pool of fluid in the vagina. We are going to test it with nitrazine, which is just good old litmus paper, and it's going to turn blue because amniotic fluid is alkaline. We're going to take a swab of that fluid, put it on a microscope slide, look at it under the microscope, and it's going to look like a fern pattern because of all the salt that's in the amniotic fluid. Really is cool. Maybe some of you got to do that whenever you were in clinical. Fetal fibronectin is a test that we could do to see if she's going to go into labor. It's actually a swab of the cervix, not a test of the amniotic fluid. And it's really a better indicator that she's not going to go into labor in 2 weeks rather than that she is in labor now. So patient teaching with premature rupture of membranes, very, very strict sterile technique with vaginal exam. It's always sterile, but it's really, really sterile whenever she has ruptured of membranes. Vigilance for infection. We have nothing in vagina if she is going to be a prolonged rupture of membranes. No sex, no tub baths, and she has to wipe front to back. She has to take antibiotics if they're prescribed because it's to ward off that chorioamnionitis. We are going to be taking her temperature every 2 hours, and if it's getting a little bit high, every 1 hour is quite fine to take it too. We're looking for fetal tachycardia. We're looking for labs tests that are going to show an infection, and that's elevation of the WBC and specifically segmented neutrophils. Because she's going to be on bed rest, we're going to want Kendall hose while she's in bed. She can take them off, get up to the bathroom, but she has to have them on while she's in bed and sleeping. And of course, we're going to assess for contractions because ruptured membranes is what's going to cause contractions very frequently. We're going to do fetal movement counts to make sure that baby is still in good shape. Biophysical profile, see if she's gaining any extra fluid. Her placenta is always making fluid, so it could be that these membranes seal over, like with an amniocentesis, and she's going to be adding to her fluid. Always, always, always be cautious of a foul smell from vaginal discharge. Now we're looking at passageway, and to that means that baby can't fit through the mom's pelvis, and that's cephalopelvic disproportion. Somewhere along in her pelvis, it is not a proper size to allow the baby to descend. So one of the things that's going to cause is labor is prolonged and protracted, so that's less than an hour or an arrest of labor. Rupture of membranes from the force of the contractions because it's pushing on the baby. Baby's not moving, but that's pressure on the amniotic sac, and she could rupture membranes. We could try a trial of labor to see if the baby can fit through, but very often it's not going to, so we're just going to do a cesarean birth. Sometimes we can switch the way the baby's presenting, have the baby flex its head more. Sometimes mom in a Trendelenburg or a knee chest position can get baby to be positioned better in the pelvis. Now with cesarean delivery, so much safer, it's almost not worth the bother. So another passageway is an episiotomy. We used to do episiotomies all the time. We thought that it was giving more room for the baby to come out, which it is, but we would do them all the time. We used to think that it was harder to repair a laceration, but actually it's not any harder. So we're going to let the mom tear rather than cut an episiotomy with scissors that would be longer than what she would have torn anyway. There could be extra damage done to the posterior wall of the vagina. She could tear periurethral tear instead of a perineal tear, and that's kind of tearing up into the urethra. That's with a face presentation is going to do that more so. Anal sphincter tears, all kinds of problems from her tearing, but truthfully, she's not going to tear as much as what we would have done the episiotomy. Again, thought to protect the bladder, but not really often. So, forceps. We don't even use forceps anymore. We would be using a kiwi vacuum extractor. A very, very rare situation is a forceps going to be used, but even if we're using either forceps or a kiwi, we're going to use it to shorten that time that mom is pushing, such as if she had heart disease. That would be a good idea for her heart not to get tachy for a very long time. Acute pulmonary edema, get that baby out. Intrapartum infection, and exhaustion. Really the real reason that we're using kiwis, because mom just simply can't push anymore. Shortens at second stage, spare pushing. Premature or fetal reason would be premature placental separation. Get that baby out. The head is right down there. We see a lot of bleeding. Put a kiwi on the baby's head and extract the baby and deliver. Fetal distress would be seen with placental separation, and this non-reassuring heartbeat, which would be seen with placental separation. So whenever we just need to get that baby out, we're going to be using kiwi, vacuum extractor, or the forceps. Risk is a laceration to a birth canal because we're not letting it expand kind of naturally. Periurethral tears, as again, is tearing up instead of down. An extension of an episiotomy into the anus or into the rectum. There can be ecchymosis on that baby's head and edema along where that suction cap was put. caput or cephalhematoma, transient facial paralysis. Parents are not happy when the baby's face does not move as well as it should. So again, this vacuum extraction, suction applied to the baby's head, looking for progressive descent. If no descent after 2 pulls, we're going to discontinue. And this is something that nurses are very vigilant about. And we just pop the kiwi off the baby's head if we can't see that there is a descent happening. The kiwi should not be kept on the baby's head because that's just that very, very long time, and it's definitely going to cause a caput or a cephalhematoma. So indication is this prolonged second stage, which is pushing, and it relieves pushing again when that poor mom is exhausted. Preferred in cases of borderline CPD, risks again, perineal tear, vaginal tear, cervical lacerations. Baby's head is usually down much further beyond the cervix then, and the same problems with the baby's head. Shoulder dystocia, one of the worst things that could happen, whereas the head is born, anterior shoulder cannot pass under the pubic arch. We've got problems then. A maternal risk is blood loss, laceration of the vagina, extension of the episiotomy, and again endometritis because of the infection that can be caused with everybody trying to manipulate that baby. Baby's risk is a birth injury related to asphyxia because the head is out. Chest really can't expand inside the vagina like that. Brachial plexus is damage to the baby's arm through this clavicle rupturing and a fracture of the humerus or the clavicle. What we're going to do is that suprapubic pressure. We're going to see where the baby's head is facing, push that shoulder to contract and get that baby out. McRoberts position, like I said in class, is where the knees are up to the ears. Kind of difficult, but we're helping her put them there. And then change the maternal position to hands and knees. Squatting or that lateral recumbent on the mom's side could help. Actually, hands and knees and squatting are the best. Just moving to those positions can help that baby be delivered then. Absolutely no fundal pressure on top of the fundus trying to get that baby down. We're just impacting that shoulder even worse. So what do? We help that mom facilitate the birth, assist with the maneuvers, document, and assess afterwards. So Group B strep, positive Group B strep is a very common infection, and it really has quite morbidity possibilities for baby if we don't know that she's infected. Once we know she's infected, we're going to treat her during labor. It does absolutely no good to treat her beforehand because we really can't get rid of it. And here's the incidence, 1.8 for every 1,000 live births. But that's enough if there's going to be a problem with it. So we have guidelines. Our first strategy is to swab her rectum and her vagina, obviously not with the same swab, between the 35-37 weeks or so, like starting in the that last month, that last month, for women with no other prenatal risk. Now, intrapartum antibiotic prophylaxis. We're just going to start prophylaxis if the culture is positive or if it's unknown. If she has a history of this, because again, we can't get rid of this. So if she has a history of one baby, it's going to be this baby as well. Presence of intrapartum risk factors like a fever, and if she had PPROM for 18 hours or more. We are going to treat her. Second strategy is just to treat everyone without prenatal care. So what we're going to do is use penicillin of one type or another as soon as she is in her labor and delivery suite, and we're going to repeat it every 4 hours until delivery. If she's allergic to penicillin, then vancomycin. But every 4 hours she's going to get a dose. We would love to have 2 doses. Let me get back to the other slide. We would love to have 2 doses before she delivers, but then we're giving every 4 hours until she does deliver. And I think I'm going to make it under the 15-minute time frame. Yay! So I'm going to post this, obviously, because you're seeing it, and this will make up for not having it in class. Thanks a lot. See you later. Bye-bye.